Hi everyone. Okay. Good evening everyone. So let us start this session. Okay. So those who are new, let me tell you about the iconic subscription where you get Unacademy and Platter, that too at a very competitive rate. And then we host a lot of special classes. You can join them, you can experience them. You just need to go to the app, download the app, use the code Dr Dixit and get access to the free special classes which are loaded with features. Yeah. And don't forget to make use of an academic question bank which is loaded with more than 25,000 plus MCQs, and that too with their authentic solutions. And please note down the tests. These are the free tests. Anyone and everyone should give them. So this is actually going to be morale boosting in your preparation, and we have a lot of batches which have already started. So let us just move forward. Let us just move forward and start with this one more masterclass series. Yeah. So let me tell you what is the ritual in this masterclass. We'll discuss one topic, we discuss one MCQ, and we discuss it in detail. So let us, yesterday we have discussed about this. Let us talk about this question now. Following is the image of breast with some discharge coming out. Identify the lesion which is shown in the image. So I hope this image speaks for everything. So this is a discharge per nipple areola complex, and this is hemorrhagic discharge. And then this is a discharge from a single lactiferous duct, isn't it? So can you tell me what is it? Yeah, sir, I am first year FMG student. Should I start preparing for next since first year? Awesome, Ambika. Awesome. Wherever you start, that is the day one. So the right time is to start preparation right at this moment only. Actually, let me tell you, if you start preparing for NEET or next, don't have any problem. You are unstoppable. If you come to my class, you'll see there are a lot of second prof students, and they answer excellent when it comes to surgery. So don't worry. You can always start with the preparation. Okay. So audience, again, I'm waiting for the answer. What it is? This is a single duct. Yeah. You can see something. Yeah. This is a single duct. So single duct with the lactiferous discharge, with a bloody discharge. So single duct with a bloody discharge. What it could be? Yeah, what it could be? Come on, tell me, students. Can you tell me what it is? This is the strongest diagnosis. So bloody discharge, along with the single duct. This is favoring in direction of IDP. What is IDP, students? Intra intraductal papilloma. So intraductal papilloma is what is IDP all about. So intraductal papilloma. IDP is what is intraductal papilloma. Let us move forward. Let us try to have a discussion of this. Okay. So this is IDP. What could be the differential diagnosis of this? The differential diagnosis, it could be malignancy, it could be duct ectasia. So it could be duct ectasia, it could be malignancy. Yeah. And what is the management plan? So shall we start the discussion? Yeah. Shall we? Okay, let us move forward. So I'll just start the discussion now. Okay. So let us, today's topic of discussion is going to be a very interesting and very important topic, that is nipple discharge. Nipple discharge. So when we talk about nipple discharge, there are three important things that you should be knowing. Yeah. What are they? What is the site? What is the site of nipple discharge? whether it is from the surface of the breast, whether it is from the surface, or whether it is from the duct. So when it is from the surface, the nipple areola complex and the discharge from the surface, the most common cause, until and unless ruled otherwise. What is the answer, students? Come on, tell me. The most common cause, until and unless ruled otherwise. What will be the answer, students? Answer is Paget's. Answer is Paget's. This is the Paget's. The second differential diagnosis could be eczema. So we have eczema, we have Paget's. So Paget's and eczema. This is very, 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 very important. What else can be the cause? What else? It could be due to psoriasis. It could be due to psoriasis. And it could be due to syphilis. So syphilis, psoriasis, eczema, Paget's, these are all very common causes of the nipple discharge from the surface. Now the query is, what is Paget's? Actually, what is Paget's all about? The Paget's is based on the theory of ductal cancers and a capacity of these cells to migrate onto the surface of the skin. So imagine if there is a cancer, if there is a malignancy in the duct, there is a theory which is known as transductal migration of the cells onto the nipple areola complex and the surface of the breast. And do you know what will happen with this? Slowly and slowly, there will be erosion of the nipple areola complex. So there is erosion. Not only there is erosion, there is encrustation. So erosion, encrustation, and also discharge from the nipple areola complex. So what is this Paget's all about? This is the superficial presentation or manifestation, manifestation of underlying cancer, of underlying malignancy. Try to understand, there's a difference between the invasion of the skin. No, Suparna, this is what I actually wanted to tell. There's a difference between the invasion of the skin. What is the concept of skin invasion? When you talk about the invasion of the skin, actually you refer to the dermal lymphatics which gets blocked with the what? It gets blocked, and therefore we get to see swelling, and this will be resulting in PUD orange. So students, PUD orange, this is equal to T4B. This is not equal to Paget's. But Paget's is like an alga. Paget's is like an alga which is spreading over the pond. So PUD orange is not a presentation. It is a superficial spread. The cancer, the malignancy confines itself to the epidermis. There is no dermal invasion. So important is, this is very, 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 very important point. There is no dermal invasion. Now, what is it associated with? What is Paget's associated with? Important is, Paget's, the most common cause, answer is ductal carcinoma in situ, more than invasive ductal cancer. Is it clear or no? Then you know that there are a lot of markers of Paget's. I'm not going to that depth, but just going to have a basic idea. Next, again, very important point that you have to understand is how to differentiate between Paget's versus eczema. Paget's versus eczema. Because both of them will have, you can say, both of them will have involvement of the skin, and we get to see encrustation. We get to see encrustation and also we get to see the discharge? The answer is involvement of nipple areolar complex. Nipple areolar complex, NAC. Paget's is always involved. Paget's is always involved. In eczema, may or may not be. May or may not be. Are you getting this or no? May or may not be. Next, very important point about this is, but if it is a Paget's involving the nipple areolar complex, then the problems will arise. What is that? This is very, 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 very important. What is that? If it is, if it is a Paget's, just a minute, students, just a minute. Okay. Let us talk about the role of steroids. The role of steroids. So eczema, they respond to steroid, and there is no response. And that is how we actually differentiate between the Paget's of the nipple areolar complex and eczema. Yeah, because it's a malignancy, it will never. Now let us talk about approach to the duct. So when we have the discharge from the duct, the next question is whether it is from the single duct or whether it is from the multiple duct. So single duct versus multiple duct. When we talk about the concept of single duct versus multiple duct, then we see the type of discharge. Type of discharge. Okay. What about the type of discharge that we have? Come on, tell me. Okay. What about the type of discharge? It could be a serous discharge. It could be a serous discharge. Now tell me, if it is a serous discharge, what is the most common cause? Student, just give me a minute. Okay. So if it is a serous discharge, what is very important thing about this? The most common cause is physiological. Why physiological? Try to understand that cuboidal epithelium is the most common epithelium which is lining the lactiferous duct, and these cuboidal epitheliums have tubules. So it's very common for a duct to give you a serous discharge. Greater than this, we have duct ectasia. Then we can get bloody discharge like we got right now. So when we talk about the bloody discharge, what is the most common cause that we have? The most common cause we have is intraductal papilloma. So intraductal papilloma, this is what you are seeing in the image. If you see this image, this is a classical image of intraductal papilloma with a bloody discharge. Let us see more important things. When we talk about the multiple duct, same question. What is the type of discharge? We can have a serous discharge. Important is, serous discharge from a single duct can be physiological. Serous discharge from single duct can be physiological, but it can never be from the multiple duct. So if it is a serous discharge, the most common cause nowadays is duct ectasia. So duct ectasia is a more important cause than fibrocystic disease. So fibrocystic disease of breast. Second is, when we talk about bloody discharge, again, the most common cause nowadays, with the advent, or you can say with the increase in lifestyle related disorders, we have duct ectasia related to diabetes and smoking. So most common cause of bloody discharge is also duct ectasia greater than malignancy. But it cannot be intraductal papilloma, because the unique thing about intraductal papilloma is that it is confined to a single lactiferous duct pathology. The third important thing is, the third is purulent discharge. So if you have purulent discharge, then the most common cause is what? Mastitis. Then we have greenish black discharge. Greenish black discharge. When we talk about greenish black discharge, students, what is the most common cause? Answer is duct ectasia. So there are classical features of duct ectasia, that is slit-like nipple retraction and a greenish black discharge. What else? What else? Five is. Okay. So bloody, purulent, greenish black discharge. Then fifth is fifth. We have milk as discharge. Milk. When we talk about milk as discharge, the most common cause is lactation, students. Most common cause is lactation. Or else we can have non-lactation causes. What are the non-lactation causes? Galactorrhea. Galactorrhea. We have galactorrhea. Now, what are the types of galactorrhea that we have? We have primary galactorrhea, which is not associated with any cause, and we have secondary, which is occurring to a pathology. So the primary galactorrhea, the most common cause is stress. So it could be physiological, it could be stress. When we talk about secondary galactorrhea, it could be due to drugs, it could be due to tumor, prolactinoma, yeah. It could be drugs, it could be tumor. What else? Yeah, tumor, that is prolactinoma. What else, students? It could be due to hypothyroidism. You know, in hypothyroidism, the hypothalamus releases TRH, and this TRH goes to the pituitary and it stimulates TSH release. Do you know it has a cross-stimulatory effect? It has a cross-stimulatory effect on the prolactin also. So it stimulates to release the prolactin. So there is increase in prolactin also. What else? It may be associated with CRF, etc. What is the management of galactorrhea? The management of galactorrhea. The first very important thing that you all have to understand is treat the cause. But how to manage this? How to manage this milk? How to manage this milk production? So in order to stop the milk, you're going to give something which is known as either a cabergoline, which is preferred because we give 0.25 to maybe 0.5 mg once or maybe twice, or if there is a severe galactorrhea, we can give BD for 2 days or 3 days and then stop it. So we have cabergoline and we have bromocriptine. So this is what. So now let us talk about approach. So approach, and this is the same approach for breast lump also. So approach to breast lump and also the nipple discharge. Whenever we get a patient with this kind of profile, breast lump or nipple discharge, what is the biggest concern that we all are having? The first concern that we are having is, could it be anything sinistral? Are we looking at a malignant patient? Yes or no? So the first, or you can say whatever you do is aimed to rule out malignancy. Is that clear? So what we do, whenever we have a patient visiting us with a breast lump or a complaint of nipple discharge, what is the first thing that we do? We do a clinical assessment. When we talk about clinical assessment, what is important? The first thing that is important is history. Why history is important, students? You need to understand the onset, the duration, the associated features, any specific site of complaint like bone pain, etc., any specific features that patient want to express you. And then, of course, since you are thinking of breast cancer, you always take a family history, whether there's any family history of say colon, say breast, etc., etc. And once you have the history, now you also go for examination. Examination. Now, when you talk about examination, what is the most important thing that you have to understand when you talk about examination? The aim behind examination is to detect any palpable mass. Simple si baat hai. So we have lot of techniques. We can go from top to bottom, bottom to top, top to bottom, bottom to top. What is this technique known as? This is known as vertical stripes. Vertical stripes. Or you can go in this circumferential rotatory manner. What is this known as? This is known as a circular method. Circular method. Or students, you can divide the breast into a dial of a clock. And then you can go from out to in, 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 out to in. And this is what is known as a dial clock method. Whatever you do, the only intention behind is to have a brief assessment. Remember, clinical assessment will not give you everything. You will not say like in Bollywood movies, we hold the pulse and say, no, this is the problem. Yeah, you must have seen, but this is not the reality. It will just give you the brief overview. Yeah. Next is, the first thing that you want now is the patient is having breast lump and a nipple discharge, or maybe nipple discharge, or impalpable lump. Where is it? So the first thing is to localize, and for localization, what is going to be helpful? Radiology. So what is the first line investigation? What is the first line investigation that we do for a breast lump or a nipple discharge? The answer is always the radiology. What is the aim behind radiology? Answer is localization. Localization. The aim is localization. Are you getting this? The next that we talk about is after localization. When we talk about radiology, the next question is what is the age? If the age is less than 35 versus more than 35, what is the challenge? Young females have dense breasts and therefore the x-rays might not be able to percolate inside, and thus you can get a false negative result. So therefore, if it is more than 35, you will go for a mammography. And if it is less than 35, you will go for USG. Are you getting this or no? One student is thinking, what about the MRI? But MRI is not the routine modality for imaging breast. It is only brought into role play in certain conditions, like when you have unknown primary tumor, yeah, or when you have unknown mets to axilla. So you have unknown mets to axilla and the routine imaging is not showing you anything. In case of pregnancy, in case of breast implants, and in case of suspected lobular pathology. So these are the only indications where you go for MRI. The next is, let us talk about the third thing. Why you want localization? Sir, I want localization because until and unless I don't localize, From where will I get the tissue? So ultimately I want tissue. And why I want to tissue? Why I want a tissue? Because I want confirmation. So next is histology. And the aim behind histology is confirmation of diagnosis, confirmation. Thank you, Bob. God bless you. So confirmation of diagnosis. I don't actually think in a way that when I'm that I should conceal the content for my routine class and this and that. Students are students. You people are sitting here with a lot of trust on me. Yeah, you're sitting here with a lot of trust on me. So always keep on teaching. And whenever I'm delivering the things, I ensure that I deliver you a substantial you can say component of this education. Definitely when you'll go for plus, you'll have a more elaborate, more wide and more, you can say, descriptive pattern of things. But yes, this is also sufficient enough for your understanding. So histology, when you talk about, the aim of the histology is to confirm the diagnosis. And therefore, why I'm teaching this? Because majority of the students are confused when to answer USG, when to answer mammo, when to answer FNA, when to answer TrueCut. So therefore, understand investigation of choice. If you ask for any lump or any nipple discharge, yeah. So if you talk about investigation of choice for any breast pathology, the answer is histology, histology, histology only. Is it clear or no? When we talk about histology, we have two options now, students. What are the two options that we have? The first is a fine needle aspiration cytology, which is done with a 22G needle. Yeah, the dispo syringe also you can use. Whenever you want to get it in hospital, we use this. So who will call pathologist to take a FNA and then they will, so we take it with syringe and prepare the smear and send it. Yeah, we take 3200, we give 500, 600, 700, whatever it is. Just joking. So TrueCut. So we have TrueCut. Yeah. So when we talk about TrueCut, this is 14G needle. So which is a wide bore needle? Answer is a TrueCut. Let us see. Now, I want to ask you 2-3 important questions. What information do you need? What information do you need from this FNA versus TrueCut? What information? Answer is, sir, I want the first thing, that whether it is benign versus malignant. Whether it is benign versus malignant. But say TrueCut can tell you and FNAC can tell you. Both of them can tell you. Students, if it is benign, then that's not a problem. But if it's malignancy, then we need to understand whether it is in situ or whether it is invasive. Why? Because the management of in situ is totally different from the invasive. It's totally different. So let us try to understand in situ versus invasive. In situ versus invasive. Now, when we talk about in situ versus invasive, you need to assess the basement membrane, and on FNA we just get a few, you can say, aggregates of cells. You cannot appreciate. So this cannot tell you, and TrueCut can tell you. So therefore, students, it should be crystal clear in your mind. Therefore, investigation of choice for a palpable lump, for a palpable equal to non-palpable. So palpable equal to non-palpable lump is equal to TrueCut is equal to gold standard. Are you getting all these things or no? So all the answers, all the question, the answer is same. Are you getting this, students? Answer is same. Next, very important thing. If this TrueCut is negative, so if you cannot comment on the TrueCut, then what to go for? Then we go for repeat TrueCut. Yeah, sure, Ambika. Sure, you can ask me. So if repeat true cut fails, then what to do? Then you have to plan for excision biopsy. Excision biopsy. Important, you have to understand that excision biopsy is the most standard, most sensitive. This is the most sensitive investigation. But it is not a routine because you don't have a plan. You do one surgery and then suppose it is found to be what, invasive, and then you have to do again surgery. Let us see. Now one student is saying, sir, then why did you write FNAC, to make mockery of this? No. So F for FNAC. Imagine if you are dealing with a benign lump, a benign looking lump. Yeah? So if you have a suspected benign lump, a query benign, if you do FNAC, you will puncture it at 4 places. Yeah. And what is the return that you get? You get a diagnosis. What is the diagnosis that you are getting, students? Come on. You're getting a diagnosis that it is benign. What is the big advantage? What is a big advantage? The advantage is that the cosmesis. You know, breast is not only organ of lactation, it's an organ of cosmesis also for the patients. And majority of the females don't want to go for surgery just because of this cosmetic or cosmetic change. Now someone said, no sir, I will do this same patient with a true cut. So true cut is a wide bore needle you have taken. So you did a true cut for this patient. When you do true cut, what are you going to get? The diagnosis you are going to get is benign. No added advantage. Rather, what is the drawback? But you are going to land up with a scar. So very important point. Very important point. FNAC is the first line. Histology. F for FNAC and F for first. So it's a first line histology for benign appearing lumps. Benign appearing lumps. Is this part clear to everyone, students? Let us move forward now. Let us talk about the management. So management of nipple discharge. The original question was, this was the original question. Now let's talk about the management plan. Important. Now, many of you must have read about ductoscopy. So use a 3 mm or 2 mm scope to enter inside the duct. 2 mm basically. So ductoscopy is optional investigation. It's not a routine investigation. It's optional investigation for nipple discharge. We have mastoscope, we have laparoscope, a lot of things. Next is treatment. When we talk about the treatment of nipple discharge, so after you have ruled out malignancy, the next thing that you have to ask is pathology. Yeah. Whether it is a single duct pathology, or whether it is a multi-duct pathology. Single duct versus multi-duct. Why? Because if it is a single duct pathology, the surgery that we are going to do is microdocectomy. If it is a multi-duct pathology, we go for a Hatfield cone excision. So Hatfield's cone excision, and this is what is known as Atkins microdocectomy. So Hatfield's cone excision or Atkins microdocectomy. And again, very important thing that you have to understand, this may be written as a radial excision. What are the parts removed? But in Hatfield cone excision versus microdocectomy, So in this, we remove the involved duct and its TDLUs. So involved duct and its terminal duct lobular units. Okay. How do we do this? This is the breast, this is the duct. So what we are going to get? We are going to get a malleable guide wire. So get a malleable guide wire, you put it inside. Okay. Or simply we use a cannula, that IV cannula, and push the push methylene blue. And then what you do? Around this duct, we make the incision. So isn't it mimicking a tennis racket? Isn't it mimicking a tennis racket? And this is what is known as tennis racket incision. Tennis racket incision. Next is, when we have multiple ducts involved, the incision that we make is a semicircle around the nipple areolar complex. We lift the nipple areolar complex up and we enter inside. And then can you see we radially excise all the nipple areolar complex, all the ducts, bactiferous ducts. So can you appreciate a cone-like excision here? Yeah. Can you appreciate a cone here? Can you see? This is why it is known as a cone excision. This is why it is known as a cone excision. So this was all about the nipple discharge. I hope I have done some justice. So for today's class, I'll discuss only this topic. So approach to the nipple discharge and its management. So I hope you enjoyed this class today, and do subscribe to Unacademy app. Do download it. Use the code Dr Dixit. And take the maximum advantage. You can join if you like the class. Do share your feedbacks, and you can join the Plus course also. We have a lot of courses for you on Plus, lot of privileges for you on the Plus. And remember, Unacademy is the technically most advanced platform right now. So what are you waiting for? Do take advantage of all these things. So till then, bye bye. I think someone was asking a question. Ambika, you wanted to ask a question. Sir, how should I go about my next preparation? My God. But you can just text me this thing on my Telegram group. So on Telegram, you can text me. My Telegram group is SX Dada. So SX Dada, you can, and there I'll share it. Okay. Don't worry. You have a lot of time. You're in first year. Ask your seniors. You have an exam tomorrow. So those who have exam tomorrow, all the best for you. All the best for INI-CET. Yeah. It's going to be there. Very soon. So till then, bye bye.